Hi, everyone. Welcome to Orthopod. My name is Mo Bandari, Editor-in-Chief of Orthoevidence, and I'm here with Dr. Darren de SA, who is an orthopedic surgeon with an interest in sports and trauma, currently assistant professor at McMaster University. Of note, he's also a team physician with the soccer and the football teams locally, both the Hamilton Tiger Cats and the Forge. Welcome, Darren.
Thank you, Dr. Barry.
Let me just get to the chase here. We have a paper that I'm aware of that will be coming out in the British Journal of Sports Medicine, likely in the next few months. But you know, the early focus of this paper has been the use of hip injections in patients with hip arthritis or osteoarthritis of the hip, varying degrees, so anywhere from mild to moderate. Bottom line, though, is they're not showing quite, I guess, the enthusiasm for various types of injectables that are being used right now to manage hip osteoarthritis. And before we get into the specific results, I'm just curious what your approach has been to, individuals who come in with either early stage or potentially even later stage osteoarthritis. I know you're primarily in sports medicine, so if you maybe want to speak from that context, that'd be great.
Yeah. Well, I mean, with regards to injection therapy for joint pain, particularly in the early arthritic population, I use injections as a kind of key component of my non-operative treatment strategy. The issue, particularly with hip pain and managing patients with hip pain, is that it kind of comes at you from different angles. So unlike other joints, say in the shoulder or the knee, where a lot of the literature is translated over, the hip's quite deep-seated. So to really understand what's driving the pain, you need kind of this layer concept starting from the joint and then working kind of outwards to the skin and the referred pain sources from the lower back and pubic area. The issue also with managing these patients is that we have now an increased focus on the patient and their preferences and their expectations, and so managing that regardless and doing so in a cost-effective and evidence-based manner poses a challenge.
Okay, so let me ask you this. I'll present you a little bit of the paper and just get your take on what you think is going on here. So there were 11 randomized trials, which in and of itself is pretty good, right? They're looking at various types of treatments. They had about just over 1,300 patients that were involved in this. And they looked at placebo, which would be the saline injection for the most part. They looked at hyaluronic acid. They also looked at corticosteroid therapy. And they also looked at platelet-rich plasma. So, sort of that's the milieu anyway that you've seen typically in the knee as well. Yes. And they also looked at a combined HA with PRP injection. So they looked at, what was available. Patients with severity anywhere from KL grades 1 all the way up through 4. So it's a mix as is almost typical in most of these studies. The majority probably being in the 2-3 range, I'm guessing, just based on what I saw in the papers. But here's what they find. They find across all of these treatments, none of them performed any better than just a saline injection. So the argument here again is what we're seeing is almost a recapitulation of what we saw in the knee, which was, maybe it's just harder to get. Maybe they're not doing it the correct way. It's possible. But, across all the different studies, which are still 11 different trials, there did not appear to be any improvement of using any of these other treatments over saline alone. Now, all of them from pre to, post in terms of, over time seemed to do well. So it wasn't as though like nothing works. It was just that overall they all seem to work the same. I wonder if that is just an error. I mean, have you had an experience with others? And again, this is taken at face value. I mean, these are small trials and, so it's quite plausible that this is just hypothesis generating. It is in fact, but I am curious how it mirrors what you've been thinking about or if it contradicts some of the things you've been thinking.
Yeah, I mean, one of the things that I kind of picked up from one of my mentors in fellowship was to kind of look at those studies that potentially either they all may show benefits, but the overall conclusion may be no difference between different treatment arms. And to look at that and to really ask yourself, does the no difference actually truly reflect the no difference, or is there something we're not capturing? And, the hard part with particularly injection therapy, at least taking it from the knee literature, is that there's significant heterogeneity across many different aspects of it in terms of doses, frequency of injections. PRP literature in general is quite, all over the place with regards to formulations, and we don't really know exactly what we're injecting. And so I think it's important that this study and the conclusions that you raise, identify, more importantly, like the need for appropriate patient selection. I think, by and large, injections for joint pain may not be applicable to every patient. And of course, we just don't understand the relative contribution of the many factors that go into one's response to them, if at all.
And they did the thing that is becoming more and more, I wouldn't say popular, but say just being used more, is this concept of the minimal clinically important difference. So to your point, even though some of these areas had a small statistically significant benefit in favor of one or the other, let's say, they believed that it wasn't big enough based on standards of statistics, that the difference wasn't big enough that it would actually matter to patients. So they said that this wasn't a clinically important difference. It may have been statistically significant, but again, that was a narrative that, quite frankly, the top sports medicine journal certainly felt was an important one to put out. So it seems to me that because it's being endorsed at this level, at some point, will be published in the British Journal of Sports Medicine as one of the top journals, if not the top in terms of impact. It does make us pause to think, is there a larger, is there just a general larger story here that we have to be considering? So what happens now when this paper comes out and showing potentially there isn't a benefit, and yet this tool of injection, as you said, is an important part of the evaluation and or treatment of patients. What do clinicians do then?
Yeah, I mean, that's a very, very important question. I think just kind of taking parallels from what we've been doing in the knee literature, I think it's important to take this evidence here, which no doubt is, methodologically sound. We have 11 RCTs. I think it highlights the, relative sparsity of the literature in this regard with regards to hip injections versus knee. But I think the next step would be to take, a consensus of, expert clinicians, lots of experience, and have us all kind of agree on terms of what we count as more important outcomes in terms of longevity. So, are we looking at 1 year, 2 year outcomes? Is it just VAS pain or function? There's a lot still to capture, I think, in this, but it's definitely a good, starting point for that. We need to look at this a little bit further.
Okay, so let me just take one step further from you. Okay, so you have a patient who comes in. In the absence of using injections, what would be your standard of care for managing someone coming in? Let's say it's an athlete coming in with, let's say, an early hip OA. What would be your general broad principles of management? And is there and when do we even consider an operation in this group at all?
Yeah, so my general principles, I believe personally in the value of manual therapy. And so I start there as a first line for most. And what I've started to do, particularly at the knee, and I translate this to the hip and the shoulder, is to truly understand the entire biomechanics that are going on. It's not just a focused exam of the hip and assessment of the hip. It's looking at the core and in the knee and referred sources. And so that's where I start. And I often do biomechanical analysis to do that with physio.
Okay.
When someone kind of makes the criteria for surgery would largely depend on if I had imaging consistent with something that, in my opinion, wouldn't respond well to a conservative approach and should be dealt with earlier, is time sensitive, or if they've demonstrated a period of time where they've given it their all, we've analyzed it as much as we can, and we're still not, we're better, but we're not there 100%.
Yeah. Okay, great. And I know that you certainly at a center that does lots and lots of procedures for the hip, and that are considered to be either reshaping procedures or labral procedures. I mean, how common are you doing those types of procedures in patients who are coming in with an arthritic pathology? Is that even an indication at this point? The same way we used to see, quite frankly, in the knee, procedures being done, for the meniscus for arthritic pathology, and that's sort of long now been changed.
Yes, I mean they still happen. What I would say is that the issue we have with the hip and other joints as well is that there's a high degree of radiographic and MRI pathology that may be asymptomatic, and so the key part is kind of distinguishing who with the labral tear actually is symptomatic from the labral tear versus the arthritis, and then to what degree. And so that's kind of where injections, I think, come in handy in both a diagnostic and therapeutic perspective. And so we still use them quite frequently in the diagnostic sense.
Okay, great. And I'll ask you the final question before we let you go here to get on with the rest of your day. Do you think that any one paper, regardless of that paper, can actually lead to a shift in how people use that particular treatment? So, for example, one paper, one meta-analysis that seems to look at all the treatments, suggesting, in fact, that injectables, at least the common ones being used, don't offer any benefit. Do you meaningfully, if you have your crystal ball, look forward? Do you think this is going to actually shift behavior, or is it going to require a lot more than just a single paper to shift this behavior going forward?
Uh, I think in and of itself, one paper, unlikely. However, this is, network malanalysis is one of the highest levels of evidence, and particularly when it's done well with many RCTs and the best available literature, it's definitely a springboard that will bring people to the table to start discussing it. The advantage that I think we have with injection therapy, which we may not have in other aspects of ortho, is that we can do direct comparisons. And so it's a springboard to show exactly what we have in the literature, where we can go forward, and how we interpret it. So it definitely is a springboard to go forward.
Yeah, great. And if nothing else, I hope it will, as you suggest, increase the debate and maybe get individuals thinking of, rather than taking 11 randomized trials to get 1,300 patients, we can certainly get 1,300 patients in a single trial, and maybe that will be the ultimate real driver of getting us to get some better data in the longer term. But thank you very much, Dr. DeSa, for taking a little bit of time with us to help us think through this paper that comes out in the British Journal of Medicine. The author is the key author and the lead author in this paper is Dr. Gazendam, and we can find the OE original report of this and the full authorship on Ortho Evidence. Thank you so much.